All right. So today is basically just going to be diathermy. We'll start covering laser therapy next time with today. So, like I said, diathermy barely made the cut. And one of the reasons why it barely made the cut is because of this. So, in our first edition of the textbook that we use, it says shortwave diathermy. That's what we're going to use. Is not commonly used in clinical practice, in part because of the variety and portability of other therapeutic heating agents. The amount of heat generated in the tissue is not easily quantified, not easily measured. So anytime we can't measure something, it gives us a little bit of a problem. And there are more contradictions associated with diathermy than other agents. So we can't measure easily. There's a lot of contraindications for it, which makes its application to a wide variety of patients problemsome. There's other forms of deep heating that we could use. So there's not a lot of patients that we use this for. So when I read that, I said, yes, we don't have to teach diathermy. And then I said, let me just make sure. Called up a handful of friends. Actually, I called up any PT that I knew and just said, I use diathermy. Do you use diathermy? And resoundingly, I said, no. What, are you kidding me? Is that what you called? He called, first time I talked to you in 5 years, you asked, that's the question you asked? Oh, yeah, how are you? How are the kids? Sorry, how do you use diathermy? And then I called up this one woman, Meg Horton, wonderful lady. She runs the rehab department in the Coventry, owned by Genesis, the Coventry Respiratory and Rehab Center, if anybody, so I might be messing up that name. Anyway, talked to her and she says, oh yeah, we use it all the time. I said, wait, what? It's not the answer I wanted to hear. She said, yeah, we use it for wounds. We get docs sending patients only to us because we heal wounds faster, better than anyone else can, because one of the reasons is because we use this diathermy. I go, oh, that complicates things for me. And I mean, Meg's one of the smartest, hardest working people I know. And if she has benefit and sees value of it, then I said, okay, maybe I can't just eliminate this. So we are going to learn it. Our points of emphasis, we're really going to learn it just for wound healing. There's other things it can do, but in clinical practice, because there's other forms of deep heating agents and because of the other contraindications for it, really it's used for wounds. Now, just a few weeks ago, actually during winter break, I was taking on more patients in the home care world. I was about to start a patient next day. I'm reading through his chart, just got discharged for a nursing home. This guy got diathermy on his quad every single day. Every single day he was there, he got diathermy on his quad just because it felt nice. And I was like, I can't believe I'm reading this. Yeah, patient requested diathermy times 20 minutes, left quad. Golly, like, so, and that's a different skilled nursing facility than what my friend runs. So it is out there. Not in the outpatient world. For few reasons for that we'll look at. But if you're in a skilled nursing facility, it might be around, and it's definitely something you can have an impact with wound care. And if it's at your facility, then you can use it for other people, and there's some nice things about it too. So anyway. So diathermy is a deep heating agent. We're going to use electromagnetic energy. Boy, that's going to put a new wrinkle in our brain to start thinking about this. It's easy to think like hot pack, hot, put it on body, body gets hot. Like that's pretty simple. Now we're going to use electricity and magnetics to create energy, and that energy is going to create heat. Boy, that's tough to think about. But we already use electromagnetic energy to heat things. Anybody have a microwave? Yeah, that's the same thing. We're using a microwave to heat somebody. Good thing about this is we can penetrate 3 to 5 centimeters below the skin surface. So how many people, when we learned about that 2 centimeter depth, we were like, all right, we're not doing anything here. 3 to 5 centimeters before too long. When I'm done lecturing, we'll grab that tape measure and visually see what does up to 5 centimeters actually look like. Fairly deep. That's not bad. All right, we're in the realm of doing something now. Good. We can increase blood flow. That's probably the number one thing we're doing when we're healing wounds. That's the biggest thing. But we can also decrease pain. That guy that I was taking on as a patient, yeah, he got it every single day because it felt nice. What does that mean when we're creating a thermal effect? It feels nice. We're introducing what? That's part of it. Non-painful stimulus, great. Yeah, if we can introduce non-painful stimulus, I'm happy. I don't care what the machine is or how silly it is. Patient likes it. If we get to put diathermy on a guy's quad for 20 minutes and then he can do great exercises to then get him home sooner, all right, I'm in. Great, not a problem. We can also increase tissue extensibility. Treatment time is about 20 minutes for thermal effects and then 30 to 60 minutes for non-thermal effects. So this is another thing where we get to play with the settings of a machine to either have a thermal effect or a non-thermal effect. This ultrasound, those are two examples of ways we can kind of tinker with settings to either generate heat or get benefit of the machine, what it's doing at the cellular level without creating a thermal effect. So here's where the wrinkle in our brain starts coming in. We're going to be using electromagnetic fields to apply externally to the body from non-ionizing radio frequency. The ionizing radio frequency energy disrupt amino acid chains that make up DNA. That's where we would use radiation for cancer treatment, X-rays. That's why we don't want to get X-rays over and over again. I don't know if anybody's gotten an X-ray. One of the questions I should ask you is when's the last time you got an X-ray? They don't want to do that over and over. Actually, the guy who invented the X-ray, he would take X-rays of his left hand every single time. And eventually his left hand just disintegrated. It was so because he didn't know, like, hey, what if this, like, tighten this screw up, take an X-ray. Okay, not quite. Do this. Okay, do it again. Kind of like anybody ever get like glasses checks where they said, how about this one? How about this one? That's what it basically was doing, and just zapping his hand over and over again. Anyway, so that's somewhere in this medical X-rays. Nice little skull there. That's menacing. This, seeing this symbol on The Simpsons, I think. So the non-ionizing energy doesn't have the ability to affect the chemical structure of tissue, but it can affect it. So what we're using in the diathermy is somewhere around the television / radio waves. The approximate frequency of the diathermy, less intense than a microwave, more intense than radio waves. So somewhere in that range. Yeah, that's it. Yep.
We're getting 3 to 5 centimeters. We're getting into a deeper muscle now.
So if we're penetrating 3 to 5 centimeters below the skin surface, we're potentially hitting deeper muscles. But again, it depends on our patient's anatomy. If they've got a glute strain and they're obese, I'm still skeptical of that. And again, it's 3 to 5 centimeters. And for diathermy, our ability to measure that is a little tough. So it's up to 5 centimeters. So I'm more optimistic of actually hitting target tissue with this than the more superficial heats, definitely. But I'm still a little skeptical. But what do we do clinically whenever we are, wondering if what we're doing is working or not? That's going to be a question we have for every single patient, every single visit. What do we do? Contraindications would say don't use it at all. Don't even think about it. What do we do? Anytime we think like, I want to strengthen this guy's quads, here are the 3 exercises I did. What do we do to?
How does it feel? Does it feel any better?
Perfect. That's one set of data. The subjective comments from the patient. Do you feel like you're getting better? Is this getting better? Do you feel like you're getting stronger? Tell me what's better in your life because of this. What else can we do? Test it, measure it. Yeah. So, you know, if you think, geez, this person's got a good layer of adipose tissue, we can penetrate up to 3 to 5 centimeters of below the skin surface. We can penetrate. Let's try it in a week or two. Let's start measuring and see if we're making a difference or not. Yeah. So the electromagnetic spectrum is just pure energy traveling through the air with magnetic and electrical fields that are perpendicular to one another. Again, examples of this are radio waves and microwaves. There's a few terms that we need to know: wavelength and frequency. So you guys have all taken physics? Was that one of the courses you had to take? Prereqs? No? Yes? No? All right. So physics wasn't a class that you had to take to get into the PTA program. All right. I'll fix that for later. All right. So the energy waves are just sine waves, just up and down, kind of like that. Okay. So the wavelength is measured peak to peak. The frequency is how many wavelengths occur per second. And these are settings I can mess with the machine. I can have a really short wavelength. I can have really tall wavelengths. I can increase the frequency, which means there's more cycles per second than here. Right? 3 cycles in this example, 2 in this example, covering roughly the same. I'm not making these extremely accurately. So when we start talking about our diathermies and especially when we get into our electrical stims, we're going to be using terms like frequency, wavelength, pulse duration. All of those things, those terms will matter to us. They all mean something. All right, that's good enough for now. So let's talk about what's happening as we plug in this diathermy machine and turn it on. We're going to convert high frequency electromagnetic energy to therapeutic heat. The electrical energy produces molecular vibration within tissue that generates heat and elevates tissue temperature. So what's happening is water molecules are dipole molecules, which means their molecules are kind of offset from one another. So they're kind of unbalanced. It's a simple way to think of it. When we introduce this electromagnetic energy to the water molecules, it's going to cause them to rotate. And as they keep rotating, that's what's going to cause the heat to generate. It's called eddy currents. Those are the closed loops of induced current circulating in planes perpendicular to the source of energy. Oh, all right. So we plug in the machine, turn it on, introduce this electromagnetic energy, water molecules start to spin. If we allow them to spin for a long time, they're going to generate heat. Just like if we were to rub our hands together, if we continuously rub our hands together, eventually we create friction, we create movement, we're going to create heat. What we can do is we can, without flicking the machine on and off, we can set the machine to cut its power on and off. So the continuous would be it's constantly going, it's constantly rubbing its hands, it's constantly making those water molecules rotate. We can do pulsed setting, which the machine is going to flick its energy on and off. It's going to basically, it's taking this power switch, just turn it on and off, on and off, on and off. And what that's doing is it's going to allow for a quick little rotation, then it's going to stop. What's going to happen to those water molecules as we cut the energy? They're going to stay still. Then it's going to turn on. Then it's going to stop, right? Then it's going to turn on. Then it's going to stop. So what that's doing is it's creating some rotation. We are going to get some of the benefits of this modality without generating heat. That's the pulsed setting. And not liking this so far.
So there's no actual water in the machine.
No, water in the person. We are the water. Yeah. 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 Yeah, no, we're the water. Yeah. Yeah. Okay.
It's the same process that happens when we're heating up food in the microwave. You only are heating up the water molecules in the food, you're not heating up the food itself.
Yeah.
So then when the water is coming from the food,
Here you go. The votes are in. Go ahead. Teach the rest of the class here, Jonathan. No, you're exactly right. And I mean, so when you guys. You're microwaving a saltine? That's what you're saying? Boy, pregnancy does some weird things. You say, wake up at 2 o'clock in the morning going, I know what I want. Microwave saltines. But I mean, that's exactly right. How many people like microwave something? There's a really hot spot and then a really cold spot. Yeah. Yep. All right. So on our diathermy, the pulse on and off settings, we're going to increase microvascular perfusion, increase oxygen and nutrient supply. We're going to help remove wastes, increase fibroblasts and macrophages, increase ATP synthesis, all really good. Where, if we were going to go back to the pain cycle, where in the pain cycle would pulsed diathermy really be impacting? Probably right after the ischemia part, the clearing of metabolic waste. We're going to improve the clearing of metabolic wastes. I think if we were to put it continuous, where we're now generating heat, now we're improving the ischemia as well as the clearing of metabolic waste. This is non-thermal, pulse non-thermal. Yep. Yep. I got some pictures in here. We have a bunch of units that we'll play with today too. So it's still going to move those molecules around, except we're giving it little off periods where it gets to cool down. The tissue's never going to heat up because we're shutting off the energy intermittently. It's still beneficial because we're still going to improve microvascular perfusion, increase oxygen and nutrient supply, remove metabolic waste, improve ATP synthesis. That's the energy that we're creating that Mary talked about in pathophysiology discussion board, right? You talked about the Krebs cycle and energy production, right? Yep. So it's also theorized that modification of cellular function is the reason of the physiologic effect. Pulse cycles are indicated for acute pain, edema control, wound healing. Again, that's the big thing I want us to take home. Again, my 3 goals: pass the licensure exam, clinical practice, and then also become employed. I don't think on a job interview you're ever going to say like, all right, don't worry, I know how to operate a diathermy machine, so just I expect a higher salary because of that. I don't think that's what. If you do, call me and I'll say, now I got to teach diathermy more. I want us to know it for wound healing. That's what I want us to know it for. Put in your back pocket, there's other things you can do with it. And if you're working at a place that has a bunch of diathermy machines, you can go far beyond what I'm going to teach you. But I think the minimal level that we are going to need to know is it for wound healing. So indications, again, number one for us, wound healing. That guy that I took on as a patient over winter break, he was using it for pain control. So yes, we can always use some, all of these modalities are good for pain control. Maybe some muscle guarding, inflammation, soft tissue tightness, reflexive heating. The reflexive heating is kind of weird. You know, if we heat the low back, we can increase blood flow to the lower extremities just because we're generating more heat, more blood supply. We're asking the body to, you know, disperse blood more. I'm really skeptical about that, but can, right? I mean, sometimes you're just at a loss. You don't know what to do. You got to start trying stuff. You got to start saying, well, this is one of those wacky things. Pelvic inflammatory disease. I don't know. I got to look back at my textbooks that I was using for this. I don't know if the improvement of delivery of medicine was with pelvic inflammatory disease or that if this bullet point should have been over. I don't know why that's indented or not. Herpes zoster skin condition. Okay, maybe. So our other deep heating that we're going to cover starting next week, probably Thursday of next week, we'll start talking about ultrasound. Ultrasound is the more common deep heating modality that we use. Cheaper, more portable, less, still a lot, but less contraindications. The benefits over ultrasound is we can heat larger areas with diathermy. The drums are bigger. We have multiple drums we could use. We can heat a big surface area of the body. The ultrasound, it's roughly 2 to 3 times the size of the ultrasound head. So that's not a lot of area. Can be used with the weight of a hot pack. When the weight of the hot pack could not be tolerated. So how many people, when they had hot packs on them, thought like, wow, this is kind of heavy. So especially now, if you've got an extremely sensitive patient, and sometimes pain can be really, really aggravating where it kicks off this whole cycle of everything hurts now. How many people have had a physical injury so bad where they can't even stand clothing touching their injury? It's not, you know. So yeah, when the weight of that hot pack can't be tolerated, well, diathermy, we're going to get close to the patient, but not come in contact with them. So that's nice. We get a deep heating without coming in contact with them. Sensitive to touch, again, another reason why this could be it. My favorite does not need therapist constant attendance. So that's great. You know, ultrasound, I've got to be there. Ultrasound requires contact with the patient. Ultrasound is weight, so that can be tough. This stuff, man, they set it. They say, okay, here's a bell, call me. I'll be doing notes. I'll be doing whatever. So that's nice. All right. Contraindications. First, metal implants. So before, when we asked about orthopedic surgeries with hot packs, our penetration depth's not big enough to impact that. Well, now we are. So we cannot use that guy that I used didn't have a knee replacement, didn't have a hip replacement. That would be contraindicated for his use. So no metal implants. Not supposed to have any metal in the treatment area. I think we'll look at the exact, I think it's 3 feet around the unit is the treatment area. So no metal in the treatment area, including jewelry, both the clinician and the patient. Anybody ever try to put a metal fork in a microwave? Jonathan, what happens? You don't know? Responsible Jonathan saying no. The instructions clearly said, do not put metal. Why would I even think to? Yeah. It's the best.
The microwave pulls off.
Yeah. All right, let's get a microwave. Where's our microwave? Is there one out there that we can? All right, so again, if I'm going to fail a class, it's going to be this one because I'm always going to forget to remove jewelry from my patient, especially, but now the clinician should not have jewelry on them either. Cardiac pacemakers. All right, in the skilled nurse facility, again, most of this in real life, diathermies are used in skilled nurse facilities and not really anywhere else. So how many of our patients who have to spend some time in the rehab facility have pacemakers? It's more than the general public. Yeah, that's if you want to find a pacemaker, I would say sniffs and casinos. Those are the two places I'm going to go look. Pregnancy for our skilled nursing facility patients, probably less of a concern, but it is a contraindication, something we're going to be careful with today. Malignancy, acute inflammation, sensory deficits, hemophilia. What's hemophilia? It's a blood clotting disorder over the eyes or testes. And any other equipment that might be adversely affected by electromagnetic radiation. So it could be sometimes patients have to wear like 24-hour heart monitors, sometimes electrodes, stickers attached to their brain to measure brain activity, anything along those lines where you say, no, I think this diathermy is going to mess up that unit. We don't want that. Precautions, we're going to remove the contact lens because it will cause it will cause the contact lens to dry out. We're going to use towels on exposed skin because we want to absorb any moisture when we're using it to create a thermal effect. So if that person starts to sweat, that sweat is highly concentrated water. What's going to happen to the water when we have diathermy? We're heating it up at a faster rate than other tissue, and now we're at risk for burns. So if we put a towel there, the towel will absorb the moisture, will be nice and safe. Over thick adipose tissue, we wouldn't want to use this over thick adipose tissue. Why do you think that is? Or it's at least a precaution. A lot of water. Yeah, a lot of water in adipose tissue. So we're going to heat it up a heck of a lot. We don't want any direct contact with the unit or cables itself. Any aching symptom that might indicate overheating. So that's that overheating, that if we're starting to generate it's a deep ache feeling, that would indicate that we're really heating up in that surface, under the surface, I should say. And the tricky thing is overheating might occur without any signs. So for us, for our hot packs, we get to look at the skin. How does this look? Like we get to have that visual inspection. This, because we're heating 3 to 5 centimeters below skin surface, we could be overheating that tissue without any signs of us to measure. It's really that patient saying, this is feeling like a deep ache. So that's part of our education. Again, part of our conversation for every single modality is indications, contraindications, precautions, patient education on why we're doing it and what they should be feeling. If we're using it for a thermal effect, you should be a gentle warming sensation. If you're feeling a deep ache, it means we're probably getting too hot. So we need to stop this. So that's part of the education that's important. 2 to 3 feet from the energy source. The energy field scatters 2 to 3 feet from the energy source. So for our clinicians who are pregnant or have some other of these contraindications, I have some clinicians have pacemakers, some clinicians have history of malignancy. We can do this. We can set the machine up. We can press it on. We can look at our patient, get them set up and be okay. And we're going to remove ourselves 2 to 3 feet from that, and we're still okay. Generally, the arms of the units are longer than those 2 to 3 feet. So we can even be messing with the equipment, and the arm that's delivering the energy is over there. There are some newer equipment that has less of a scatter than older ones. So your machine that you see in your clinic might have a really focal energy scatter. But that is important for us to also think, like, why is it less common in outpatient places if diathermy is this great thing? Why do you think? Space. Yeah, we got to keep everyone else away from this, because I can't use it on Kiki if he's sitting next to another patient. And if that other patient's not mine, I might not know if they're pregnant. I might not know if they have heart attack. Or a pacemaker. I might not know if they have history of cancer, right? So that person is at risk, even though I'm using a Kiki that is fine. It has none of those contraindications. So that is something that In the outpatient world, that space is a limiting factor. SNFs have space, we have private rooms, we have, we can figure that out a little bit easier.
So is that the reason why they have to remove their contact lenses? Because I'm looking to figure out the top one, you said obviously not around the eyes. I'm figuring that.
Yeah.
But then this one for the precaution says remove lenses. So I'm like, is it that much? Like if you're doing my hand, I have to remove my contact lenses? Is it?
Yeah, 2 to 3 feet. I mean, we're close to 3 feet if you're doing hand to eyes. Yeah. Yeah.
Oh, okay.
Yep. And especially even we're doing hand, if you've got earrings on, okay, well, that's within this scatter, the energy scatter. Yeah. Start seeing little lightning bolts coming out of your jewelry. We don't. So again, I want us to be really good at knowing how to use it for wounds. That is what I want you to know. I want you to have a couple of other tricks in your back pocket should you need to. One of the ways we can use this in a few different ways, there's a handful of different ways we can use this. We can use a capacitance method, which we have 2 plates for, and here's a picture of that. So we have 2 drums creating an energy field, and basically the energy field of one is going to go deep and go towards the other side. So that's a fun way to do that. There are other pads that we could use too, not drums, but pads, and we would adhere the pads to the patient. So we need 2 plates, 2 drums to create that magnetic field. Plates are parallel to the structure being treated, or medial lateral, so the structure passes through the structure, not anterior posterior. What we would want is, if we're using it in this method, our target tissue is 3 to 5 centimeters below the surface, somewhere in the middle between these 2 drums. So our target tissue looks like kind of low thoracic, high lumbar area. That's what I would guess there.
It's just safe that she's wearing a belt because you said punch intervention is no metal.
No metal. There might not be metal on the belt. If there is, I would remove it. Yeah. She's also wearing contact lenses. Can't do that. All right. Based on haircut alone, when was this picture taken? Early 90s, you think? Yeah, I think you're right. Yeah, that's a. She strained her back, healing the stegosaurus from the belly ache, and then. Yeah, they would have it. Yeah, that's how they made the dinosaurs. Actually, they said, "I know, grab the frog, grab the ember, put them in a diathermy unit. 9 months later, you get a dinosaur." So with this capacitive method, the thought is that the wavelengths penetrate deeper, although I went a little crazy looking at all right, give me these 10 textbooks. What do they say about diathermy? And everybody, frustrating thing is a lot of them have conflicting advice. So some conflicting resources cite differently that the wavelengths do not penetrate deeper. Okay, fine. Again, clinically thinking, I would think okay, well, I'm going to use 1 drum. That's what I'm going to teach you today and expect you to know. If it's not working after your 2 weeks or a week or 2 of treatment, the next thing you could do is say, well, let's try this capacitance method and just see if it penetrates deeper. That's one of the thought processes you can have. Non-uniform heat due to different concentration of water molecules within the tissue. But this method is best to increase the tissue extensibility. So I do want you to know that if you want to use the capacitance method, it is best to increase the tissue extensibility. With this method, this 2-drum method, yes. Flexibility, making it move. We're going to use the single drum application for it. That's the inductive coil method. Magnetic field passed through tissues caused by the eddy currents closer to the surface of the drum, theoretically, again. More heating superficially, again, different resources cite differently, so not really going to hang my hat on that. But the single coil method is best to increase blood flow and thus heal wounds. Here's some pictures of diathermy machines. So frequency of waves, how many waves per second? 27.12 megahertz is the most common. We can use between 10 and 100 megahertz. Most machines are fixed at 27.12. I don't have any reasons why we would mess with that setting. When you become diathermy experts, you call me up and say, hey, Josh, when you teach diathermy, can I teach it the right way? Jonathan will come back and say, don't worry, guys, I got it. All right, so that'll be good. So that's kind of like our standard. I don't think we should be messing with that. 27.12, great, we got it. Their next decision making is, do we want heating or not? If we want heating, do we want pulsed or continuous? We would want continuous if we want heating. If we don't want heating, pulsed. What would make us think we want heating or not? One of the times we would want heating. I think we can stimulate blood flow on pulsed as well. I think pain is probably the number one. If we want to increase that non-painful stimulus, I need a stimulus to help me with that. If it's pulsed, they're not going to feel anything. And if they don't feel anything, we're not introducing non-painful stimulus. So I think that's the number one reason we would do continuous, is when we want pain relief. Any reasons we would say, I'm looking at this, we don't want heating? Inflammation, yeah. First 72 hours after an injury, just off the bat. Yeah. Anything else? Tell me why. Yeah. Fevers, yeah, and because fevers is a sign of an early sign of potentially infection. Don't want that. Yeah. Any other reasons you would want to stay away from heating? I think those are good ones. Edema, potentially. Potentially, we're a little stop and think thing is edema, not necessarily don't do it, but acute inflammation, I do think. Yeah. And then our next question is, do we want to increase tissue extensibility, increase the tissue flexibility, or do we want to increase blood flow? If we want to increase tissue extensibility, what are we going to use? Capacitance 2-drum method or inductive 1-drum? Capacitance 2-drum method. Yeah, so that's my simplified thought process. Again, when you become diathermy experts, come teach me the other ways to do it. But that's my simplified process to it. And if you understand that these two questions, the parameters when you would want heating or not heating, want tissue extensibility or not, you're going to pass any question on a written exam for me. And I think for your licensure exam, if you can just work your way through those two thought processes. So the parameters we have, we already talked about parameters. The parameters we already talked about was how hot should the water be? Parameters were how hot should the paraffin be, right? So we have talked about parameters already. We just have more parameters we get to play with. So we can play with how many pulses per second we want to use. Our ranges, but I have direct guidance, I think, in the next slide. Yeah, a few slides from now. But the diathermy, we can range from 10 pulses per second to 800 pulses per second. Well, that's a lot of pulses. That's pretty cool. And this is where, I mean, it starts hurting my brain because you go, wait a minute, how long is a second? 1/1000. Okay, that's a second. So you're going to tell me this machine is flicking on and off 800 times in 1 Mississippi. Wow, I don't know if I can flick that toggle switch that fast. That's pretty good. Probably why they use a machine and not me. The pulse duration. How long is the on switch on for? Measured in microseconds. So, all right, we're just getting some really weird numbers now. How long is, so the units can range from 200 to 400 microseconds. Some units are fixed at 400. How long is it? 400 microsecond. What the heck are we talking about? It's a short amount of time. And then the intensity we're going to measure in watts. It's basically how anybody when we see the words watts, is that we have a real life example of when we use watts? Light bulbs. Yeah, great. So what's a 60-watt light bulb versus a 100-watt light bulb? Which one is brighter? Yeah. So we already know what a watt is. We already use it. Anybody ever not change a light bulb? Good. So we're going to measure how much energy we're introducing into the tissue measured in watts. How bright of a light bulb are we using today? We can measure it either with the peak. So when it's on, how bright is the light bulb? Or we're going to take the average, which means, yes, the light bulb is 100 watts, but if it's only on for half a second, my average I'm delivering to the patient is only 50 watts. So that's what that means. So here's kind of the picture of, I know it's a little blurry here, but my pulse width is how long is the machine on for? How many cycles is it on for? What is my peak power? But because it's only on at so often, my average power that I'm delivering to the patient is way down here. So we have a Chattanooga, I believe this is the Chattanooga machine here. So here is the Chattanooga machine, the Chattanooga Diathermy machine. Once we turn this on and play with it, we'll figure it out. But that has a preset diathermy levels. Dose 1, dose 2, dose 3, dose 4. And all it is you just figure out, okay, we have acute inflammation. I want to do dose 1. And it just presets all of its parameters. That's nice. So for acute inflammation, that would be just below the point of any sensation of heat. Subacute will have mild heating. To resolve the inflammatory process, we'll have moderate heating. If with chronic conditions, we'd want heavy heating, vigorous heating, but should be comfortable. Again, the settings are anywhere between 13.56 megahertz and 40.68 megahertz. Again, 27.12 is the most common. I don't see a reason to deviate from that. But here is, on the other machine, we have to dial everything in. So here's what the parameters that I want you to know and understand. What should my pulse frequency be? What should my pulse width be? What should my peak intensity be? And what is my treatment time? So my pulse frequency for acute wounds, we're going to have 10 pulses per second. My duration or pulse width, and that pulse width refers to how much time is the machine on for. 65 microseconds. My peak intensity is going to be between 50 and 100 watts. Adjusted to their patient's report. If they're feeling, if we're doing acute wounds, what's the sensation we want? What do we just say? Barely anything. It should feel like almost nothing. So we have this range between 50 and 100 watts. We get to mess around with that depending on patient's report. Subacute wounds, 50 pulses per second, 200 microsecond pulse width, 50 to 100 watts, and chronic wounds. We have 400 pulses per second, 400 pulse width, and our peak intensity, if it's a chronic wound, between 150 and 200. If it's a diabetic ulcer, between 50 and 150. I don't know why. I'm thinking because anybody want to try to give a reason why diabetic ulcers were way more conservative on the amount of power we're giving? There's one reason. Wait, not rupture. What's that? No, I don't think so. Yep. I think it's because if you have a diabetic ulcer, it also means you have impaired sensation. And if you have impaired sensation, how are you going to know if it's too hot? You're not going to feel it. So let's be really careful. And the treatment time for any of this would be 30 minutes. So we'll mess around with the units. There should be off buttons. I believe these have off buttons to them where if the patient feels uncomfortable, they get to press it right away. Anytime we leave our patients, they should be given, if we're attaching them to a machine, we've got a handful of machines we're going to be using throughout this semester, they should be given an on-off button. If we're going to be leaving them. And it's even with our hot packs, I'm going to be leaving you. Here's a bell if you need something, whether it's one of those, metal bells that you ding at the wait desk, or I know some people use. Anybody have like those battery operated doorbells? Anybody ever see those? Those are easy. So patients should be given an on-off button, call bell, some way to contact us if something's not feeling good. To document, we'll say we did the diathermy on what location of their body, inductive or capacitive method, pulsar continuous, and then whatever our parameters are. And our parameters should be one of these. Again, I want you to know it for wounds. This is what I want you to know and understand. That's what I want you to be experts on. Okay. Now today we're going to mess around with these a bunch. So feel free to play around with, okay, let's figure out this capacitance method. Let's figure out what does it feel like. Most people report it's a nice warming sensation. It's actually pretty surprising how nice it feels and how you can feel it. It's a little freaky though, because like with a hot pack, I know it's hot. I can feel it's hot. I feel it with paraffin. Okay, it's just hot. Like this, all of a sudden, we're just sitting there and you go, oh, it's feeling a little warm. And it's a little weird at first, a little magic trick. Chris Angel would be very impressed. All right, so let's do this. Let's take a little break, fill up your waters, think about microwaves as you fill them up. And then when we get back, we'll start messing around with them. Okay?